So, aspirants, we'll be starting our session. The topic for today is acute renal failure, and the speaker that we have here is Dr. Nikhilesh Jain, sir. He is a director and operational head, Department of Critical Care Services at CHL Hospital, Indore. Thank you, sir. So, you may carry on.
Sure. Okay, so over the course of about next half an hour, 40 minutes, we would be going through the sum of the final points of acute kidney injury, not in full details, but at least how they are asked in EDIC and what are the things we are supposed to look at, right? So these are the various case vignettes, and from then on, we would migrate on to questions in the latter half of the presentation. We've got a 64-year-old male, diabetic and hypertensive, presents with septic shock secondary to pneumonia. He is hypotensive, BP of 80 by 40 mm of mercury despite fluids and is currently on noradrenaline. Now, urine output has fallen to less than 0.3 mils per kg per hour for 10 hours, and serum creatinine has risen from 1.1 milligram per deciliter to 2.4 milligram per deciliter in 24 hours. You do a renal Doppler, which shows an elevated renal resistive index of 0.82 bilaterally. So these are the questions that can come out of this, right? So according to KDIGO, what is the stage of acute kidney injury in this patient and how will you define it by urine output and creatinine criteria? Now, what exactly does a renal resistive index of more than 0.8 suggest in this clinical setting? And how reliable will it be as a marker for predicting renal recovery? You have to outline key management priorities in sepsis-induced AKI, including hemodynamic optimization and nephrotoxin avoidance. The timing of initiation of renal replacement therapy comes as a question. Which modality comes as a question, and why are you preferring it comes as a question. Now, during CRRT, the transmembrane pressure rises rapidly. So, what are the possible causes and corrective measures? Of course, this would come. This would be the second case. You've got a 45-year-old construction worker is found unconscious after being trapped under debris for 6 hours. Labs show a total CPK of 85,000 per international units per liter, creatinine of 3.8 milligram per deciliter, potassium of 6.5 millimoles per liter. Urine is dark brown, dipstick positive for blood, but no RBCs and microscopy. This guy is olivuric. He's got metabolic acidosis with a pH of 7.8, 7.18. So the common questions that can arise out of this would be, you stage the acute kidney injury and explain how creatine kinetics differ in rhabdomyolysis compared to other acute kidney injury causes. Then what are the diagnostic hallmarks of rhabdomyolysis induced AKI and how do CT and ultrasound help in ruling out other causes? You discuss your fluid management strategies, urine alkalinization and role of mannitol in this case, indication for renal replacement therapy, which form of RRT would be best suited, and what are the key considerations in filter clogging which can happen because of myoglobin levels. CRRT filter clots within 2 hours of initiation, what are the possible causes and preventive measures? These are certain common questions that can arise out of such a scenario. Third one, 70-year-old female with chronic kidney disease, baseline creatinine of 1.6 milligram per deciliter, undergoes coronary angiography for non-ST elevation MI. 48 hours later, her creatinine is 2.6 milligram per deciliter, and urine output is around 400 mils in 24 hours, right? In the oliguric range. That is. You do a bedside ultrasound which shows a normal kidney size and echo texture. You do a renal resistive index value and you get it as 0.68. So you identify the stage of acute kidney injury again using KDIGO criteria. That is important. What are key diagnostic features distinguishing contrast-induced acute injury from other causes such as atherosclerotic renal disease? Prevention strategies is something that you should be aware of in terms of IV hydration, use of low osmolar contrast agents, N-acetylcysteine, statins, what is their current role and what is their current place as per evidence of therapy. Is prophylactic RRT indicated post-procedure? We need to sort that out. What does current evidence suggest regarding high volume hemofiltration for contrast-induced injury to AKI prevention? If you do an intermittent hemodialysis, you get hypotension and ultrafiltration failure. And how would you adjust your ultrafiltration goals? How would you adjust your dialysate sodium? Do you need to manage your temperature to handle this? So all these questions can form part of your EDIC testing. Totally, we'll be doing around 5 cases. This will be 4. And then after this case vignettes, the questions will start. So case 4 would be a 58-year-old male, acute decompensated heart failure, ejection fraction of 25%, HFrEF basically, presents with worsening dyspnea and oliguria. You get a creat of 2.1 milligram per deciliter, baseline of 1. You get BNP values, which are 2,400 picograms per ml. Echo-wise, you get a dilated left ventricle and elevated right atrial pressure. You do an ultrasound, you get more of B lines, you get a plethoric IVC, and you get a resistive index, which is to the tune of around 0.85. Questions that can come out of this: what type of cardiorenal syndrome is this? What are its defining features? How would actually renal replacement therapy help in differentiate? Oh, sorry. I'm sorry. How does renal resistive index help in differentiating congestive from hypoperfusive AKI? You need to outline your diuretic strategies, loop diuretic infusion, namely versus combination with thiazides. What are the hemodynamic targets for renal protection? That is what you should be aware of, and that is what you should know. When should you consider ultrafiltration? And how does this compare to a pharmacologic decongestion? During SLED, this patient would develop hypotension and arrhythmia. So, what immediate adjustments can be made so that instability, hemodynamic instability, which comes recurrently, can be prevented?